Hello, everyone, and thank you for the opportunity today to discuss our team approach for dual lumen bedside cannulation under the COVID ECMO pandemic. My name is Errol Bush, and I'm the Surgical Director of the Advanced Lung Disease and Lung Transplant Program at Johns Hopkins Medicine.
And my name is Stephanie Cha. I am a cardiothoracic anesthesiologist and intensivist at Johns Hopkins, and we are very excited and honored to be here at the American Association of Thoracic Surgeons. I do have to disclose that I provide an educational consultantship with MC3.
And I have no relevant disclosures and have not accepted any compensation for this discussion today.
So what does ECMO for ARDS in the COVID era look like? Well, this screenshot comes from the ALSO Registry's COVID dashboard. And we can see here a sense of the total number of reported COVID cases to ECMO, as well as patients initiated on ECMO therapy, as well as the ongoing in-hospital mortality. Just recently in 2021, ALSO released a set of guidelines to update their interim guidelines of last April. And they did describe that patients who are supported with ECMO for COVID ARDS do demonstrate similar mortality with patients who are supported by ECMO for ARDS of other etiologies. However, the COVID cohort does appear to have a longer duration of ECMO support with a mean run of around 18 days. The guidelines also describe that selection of patients must consider the hospital's current resource capacity. And so certainly during surges, we may need to be more stringent with our criteria in terms of which patients we select for ECMO therapy. A very important change from the interim guidelines does state that two-site, multi-site, and dual lumen veno-venous techniques are all appropriate cannulation strategies. And we will discuss dual lumen veno-venous techniques in great detail, but this was an important change because last April, the recommendations, they stated that they could not make any recommendation with this technique specifically. Finally, it's important to refer patients earlier and to utilize mobile ECMO programs when feasible.
Our Johns Hopkins guidelines for ECMO are demonstrated here on the screen. What I'd like to highlight is that we actually use ECMO more as a salvage therapy, and that really patients have before ECMO deployment have to demonstrate that they've failed their adjunctive techniques that include ARDSNet protocol or high PEEP utilization, prone positioning, or inhaled nitric oxide or other vasodilator therapies prior to consideration of ECMO deployment. In general, those patients that have a PF ratio of less than 80 for 6 hours or less than 50 for 3 hours, we would consider, but does not mean that each patient that meets this criteria would be cannulated. We found that in COVID, that many of the patients, especially after the first surge, really suffer from hypercarbic respiratory failure instead of hypoxic respiratory failure. And so having guidelines on hypercarbia is important. And we utilize acidosis with a pH less than 7.25 and a PCO2 greater than 60 as our criteria for consideration of cannulation. We do have a list of relative and definitive contraindications or exclusion criteria that include age greater than 60, BMI greater than 40, or mechanical ventilation greater than or equal to 7 days. We find that these are relative contraindications because if someone's 61 doesn't mean that we absolutely decline them, but really it has to be balanced with their other comorbidities. However, when patients have a poor or unknown neurological status or other comorbidities that would lend towards a poor prognosis or limited lifespan because of those comorbidities, then these are more absolute contraindications for ECMO deployment in our program. I've highlighted here what our experience has been during the COVID pandemic. So approximately a year since March of last year of our COVID ECMO VV ECMO deployment. And you can see that we've developed a institutional preference towards dual lumen cannulation, and that we've had 17 patients that were cannulated at the bedside with a dual lumen cannula versus our more traditional cannulation strategies of FIM-IJ of 8 and FIM-FIM cannulation of 2. The survival of these patients have been approximately 53% of survival to discharge. Of those survivors, the average run is about 26 days. We've seen from these survivors that between 8 to 66 days, we've seen recovery. Our longest patient has been about 110 days, but unfortunately did not survive before developing complications of ECMO. And although the 53% is similar to what's been shown in other case series of the COVID experience, what we were surprised to find out is that our patients that had dual lumen cannulation actually had a much better survival of approximately 71%, compared to those that had a single lumen cannulation strategy of approximately 30% over that same period.
There are some unique physiologic considerations that we must consider in the COVID population, and these inform both our cannulation strategies and how we manage the ECMO flow rates after cannulation. The most important of which is that we find that our COVID patients demonstrate a very high cardiac output state. This may be due to their septic profile, but it may also be because many of these patients are young with relatively robust hemodynamics. This is important because the greater the cardiac output, the greater the necessary flow rates, which are required to minimize shunting and refractory hypoxemia after cannulation. In addition, as you've seen, some of our patients have had recoveries upward of 2 months. And so we would like to plan for these long recoveries by minimizing the risk of hospital-associated complications, such as infections or thromboses, which may inform our site of cannulation. And finally, as you'll see, there are a number of infection control measures that we deploy in our program to protect both our patients as well as the staff providing care for them. What does our ECMO program look like? So here is a photo from our ICU, and this is what we lovingly call our crash corner. And as you can see here, we have our normal backup ECMO circuit, balloon pump, computer for our resident perfusionist. But what's really dominated the landscape recently are these blue carts. And these are our peripheral ECMO carts designed to be deployed to the bedside wherever a patient may need to be cannulated. And you can see hanging off the back of the carts here are the cannulas themselves. We're very proud that the carts have been designed such that the labeling is easy to use by personnel who may not be trained or familiar with life in the operating rooms. And so here we can have bedside ICU nurses who have no surgical experience help us retrieve equipment from these drawers. Lately, we've downsided this cart even further, and on the right-hand side, you can see this bag of supplies that we call our ECMO Go bag. And so now, when we hear about a cannulation, a fellow can take one of these bags, grab a cannula off the cart, and go right to the bedside to meet the team for cannulation.
I'd like to talk about how we've chosen our cannulation strategies and what particular advantages there may be. The discussion between single lumen and dual lumen cannulation advantages and disadvantages continues, with proponents of single lumen cannulation arguing that this technique offers a faster cannulation strategy. They may be less positional and can result in higher ECMO flows. But we haven't had the same experience. With our dual lumen cannulation, the proponents of this strategy would argue that bicable drainage with less recirculation is a physiologic advantage that can help with patients' recovery. And in fact, with the SVC drainage being the most deoxygenated blood that's returning to the atrium, if it's not included in the circuit, then there's more competition with the return or the outflow circulation from the ECMO circuit, and it may not meet the physiologic demands of the patient. And obviously having less recirculation with the dual lumen cannulations is an even greater advantage for ECMO efficiency. Having the single insertion site is also a potential advantage for patients, especially as we're starting to try to lessen their sedation or have them participate in rehabilitation so that they're able to sit more upright in bed, they can get out of bed and participate with physical therapy, or even if they're deconditioned enough that they can only do leg movements or rehabilitation maneuvers, then not having a cannula in the groin would be advantageous in this situation. I've highlighted the more prominent dual lumen catheters that are used for VV ECMO, the Crescent Jugular Dual Lumen Catheter and the Avalon Elite Bicable Dual Lumen Catheter. We can see that by design, these dual lumen catheters are really similar in their design and their catheter deployment. However, we've noticed that with the Crescent catheter that it's more able to meet the physiologic demands of our patients, and why we've taken this preference in its utilization. From the ELSO registry in 2016, this report actually highlights some advantages of dual lumen cannulation for VV ECMO that many people aren't aware has been previously published. We are all accustomed to the data that cardiogenic shock and ECMO tends to have worse outcomes than respiratory failure ECMO. But how many of us remember or recall that dual lumen cannulation has been shown to have increased survival outcomes over more traditional veno-venous strategies? So we see in this 2016 report that looking at all ECMO populations of neonatal, pediatric, and adult ECMO runs, that the survival benefit ranges between 5 to 10% over single lumen cannulation techniques. We find this to be a significant advantage and consistent with the data that I've shown you that we found in our COVID cohort, that dual lumen cannulation offers a survival outcome benefit over single lumen strategies. Here in showing why that may be, why that benefit may be achieved, and looking at the Avalon and the Crescent catheters I've taken from both manufacturers' websites, their flow curves for their particular size catheters, and we see that while the size ranges may be pretty similar, that the Crescent catheter can achieve higher flow rates at less pressure. And it's certainly been within our experience that with Crescent cannulation, that we consistently achieve between 5.5 to 7 liters per minute of flow with the Crescent catheter, but only achieving between 4.5 and 5.5 liters per minute with the Avalon catheter. Whereas this difference may not have been significant for our non-COVID populations. As Dr. Cha mentioned, that we've found in our COVID population, these patients have high cardiac output and they need a higher flow rate in order to meet their physiologic demands. And so we found that our patients have had much better matched perfusion and ECMO flow when using the Crescent catheter.
An important note is that placement of these dual lumen cannulas does require visual guidance. You can utilize either transesophageal echocardiography or TEE or fluoroscopy, and this may just depend on which resource is more readily available at your hospital. Our program utilizes TEE not only because it avoids radiation exposure, but more importantly, it avoids needing to transport an unstable patient to an OR room. We have dedicated TEE machines for use in our COVID cohort. And we also have a protocol for processing these machines and cleaning them in between patient uses. It should be noted that TEE does require expert echocardiography, and we're very fortunate to have a very deep cardiothoracic anesthesiology roster who can be available on call for these bedside procedures. Fluoroscopy, of course, has the benefit in which the proceduralist or user can control visualization while continuously monitoring both the wire and cannula position during placement.
Now I'd like to highlight how we safely perform bedside cannulation. And over the next series of slides and videos, we'll show you how we assemble our cannulation team at the bedside, how we organize the equipment and tools that we'll need to safely deploy ECMO, and then how we access the vessels and prepare the cannula to be placed appropriately into position before securing the catheter for long-term use. So the first picture here demonstrates how we set up our ICU room. And this is a large room, but it becomes small very quickly as soon as you bring in all the necessary team members and equipment that are necessary to do this. So first, just having an organized structure, and you see the patient's head is to the left in the first picture on the left, and his feet are down to the bottom. At the patient's right is a patient's a bedside meal tray that has been covered to create the sterile field. And the TEE equipment is over to the patient's left, where the anesthesiologist or echocardiographer will stand during this during the deployment. You see the picture in the middle demonstrates our team personnel that are in the room. The person who's the surgeon is standing at the head, as well as myself, who functions as an assistant in this particular team, will be to the patient's right. And then before we actually cannulate, there's a pause to make sure that we communicate all the necessary steps that everyone will be involved in. So one of the most important things is to make sure that your sterile field is protected and that nothing falls off of that field. What we see are I've minimized the equipment that we need during this. So there are only 4 tubing clamps, a pair of scissors, and a needle driver, as well as the cannulation access kit that is on the table with a bowl of saline and an asepto syringe in order to distribute that saline as needed. Because the table is so small and you have equipment that is very important that you don't want to happen to fall off the table and you need to replace because it may not be easy to replace quickly, I use a technique where we wet the surgical towels so that they provide a weight onto this very important equipment. And then one of the first things that we'll do once we've set up our table is to actually assemble the cannula so that it can then be taken off of that small table and then more appropriately secured on the patient in the middle, in the patient's picture on the right. You see that the cannula is secured between the patient's leg on the bed. That provides a more stable environment. Now we'll show how we prepare and access the vessel. And so most of our patients actually have a right IJ catheter already placed for their ICU care before we get the call for ECMO deployment. And so it's easy for us to exchange that catheter over a guide wire before then deploying our cannula. What we'd like to do in the middle picture is, before getting to the step of dilating and cannulating, is that once we make the skin incision for the venotomy, that we place a purse string suture around that venotomy, such that if there are any difficulties gaining further access with the dilator or the cannula, that we're able to close that venotomy, or even what's more more likely to be used for is in the decannulation process. When we remove that large cannula from the neck, we already have a purse string in place so that we can immediately close the venotomy without hemorrhage. And then finally, we'll show you how we safely dilate using this one size fits all from about a 6 French up to a 32 French catheter. So this video will show the safe dilation. Notice that the one size catheter, which can be kind of daunting, is inserted into the skin nick into the vein, and then it will slowly and carefully be dilated or inserted in order to dilate up to a 32 French. Now we see that technique. The surgeon is inserting the dilator. It happens very smoothly. Remember, it should be controlled, but you want to make sure you go in and out several times out of the skin and into the vein to make sure that when you actually do deploy the cannula next, that it doesn't get hung up on any of the soft tissue. So it's very important before you insert the cannula that you orient it in the direction or the anticipated direction that it would need to be for the arterial or the atrial infusion. And that is a position where the red limb or the atrial infusion limb will be oriented anteriorly and towards the left slightly in the direction where the tricuspid valve would be anticipated. And then once we've inserted the cannula, we make sure that it's in the desired position, which is managed with TEE assistance. In this video, again, we'll show how the cannula is oriented. Now, even though this venotomy has been dilated to 32 French, if you notice, you can engage the cannula without actually inserting it, and it will occlude the vein so that there's not hemorrhage. And therefore, in a controlled manner, you can orient the cannula correctly, anteriorly and slightly towards the left, in the position that would be expected. And so notice here, the assistant is getting his hands, or sorry, the surgeon who's at the head of the bed will get his or her hands in the correct position so that this can be a safe and controlled deployment, while the assistant is going to maintain the guide wire in the proper position and make sure that it doesn't get advanced or retracted during that deployment. So you'll notice this all happens quickly here. My hand is to the left and above the surgeon's hand. The surgeon's thumb will hold the dilator in place to make sure it's not retracted during this nice controlled deployment. And if you see that this is really a controlled deployment technique, but that it can be expediently deployed, so that we find, again, that dual lumen cannulation can be just as fast as single lumen cannulation techniques, especially since you only need to insert in one spot. And our preference is to insert the cannula all the way to the hub of the cannula, which is noted by that suture, the gold suture collar, because once we remove the guide wire and go on ECMO connected to the circuit, then we can retract the cannula under TEE guidance to make sure that the atrial infusion jet is in the appropriate position. And finally, once we've confirmed the jet is in the right position, then we'll connect it to the circuit. You're looking for color change so that you confirm that oxygen is flowing well to the ECMO circuit, but also that the circuit is working and has its intended benefit to for respiratory support for the patient. And then we'll secure it with 2 sutures on each side of the venotomy incision around the accessory suture collar. And then using the gold suture collar, another suture secures the cannula before wrapping our purse string suture around the cannula for later use.
So now let's talk about how TEE can be used to both guide placement of the cannula and assess the position of the cannula once in place. Here we see a basic outline of the steps that will parallel the steps you've just heard about the cannula placement. And in summary, the steps are to first perform a basic cardiac examination, to then visualize the wire as it is coming from the SVC into the right atrium, to assure that the wire does not become malpositioned or deformed during dilation and placement of the cannula, to visualize the cannula if possible as it is being placed over the wire, and then to use color flow Doppler to assess the jet or flow from the outflow lumen of the dual lumen cannula in its correct position. And we will go through all of these steps in a little more detail. So again, the very first step is to perform a basic cardiac examination. While many of these patients have hyperdynamic circulations, it is important to rule out a pre-existing acute or chronic cardiomyopathy that might render a veno-venous technique inappropriate. In addition, it's a good time to familiarize ourselves with the basic anatomy of this patient. And what we see in the center of the screen is what we call a bicaval view, because we are viewing the right atrium, this black chamber here. But in this view, we can visualize both the SVC on the right-hand side of the screen, as well as the IVC. And down towards 7 o'clock, we see the location of what should be the tricuspid valve. Another very important view is the hepatic view. And so here we've advanced our probe a little further into the liver, and we see all of this white kind of homogeneous looking tissue here that depicts the liver tissue itself. And importantly, we see through the liver, the hepatic portion of the IVC and one of the hepatic vein branches that comes off of the IVC. Again, here's our home base view, our bicaval view. Here is our right atrium. On the right-hand side of the screen, we see the SVC. On the left-hand side of the screen, the IVC. And down here is the tricuspid valve. And up in the upper right corner, you can see a cartoon that depicts this anatomy a little more clearly. And here you can also see that ultimately our dual lumen catheter will lay across both cava up top. And ideally, the outflow lumen will be positioned just above this tricuspid valve here. Now, the first step is to visualize the wire passage into the right atrium. Often patients have a pre-existing right central line that we can place a wire through one of the lumens. And this J wire that you can see visualized in the right atrium is a standard wire that comes from any central line kit. Sometimes the patients will require a new vascular access in which we can use ultrasound both to guide placement of the cannulation as well as then the visualization of the wire into the right atrium. The next step is actually to follow that wire into the liver. And so here again, we see our hepatic view. Here's the hepatic tissue. And this column here represents the hepatic portion of the IVC. And we can see the wire coming down into the IVC and importantly, excluding or not having its passage terminate in one of the hepatic veins, which is a much smaller vessel. Next, we're visualizing the heart and the wire position during the series of dilators. This may not be a very exciting portion of the TEE exam, but it's very important, as we'll see later. And what's most important is to visualize this wire, again, coming from the SVC down into the IVC as this sort of linear, straight structure that doesn't undergo any bowing or bending or deformation as the dilators are being applied. Here we actually see a clip of the cannula coming into the right atrium. The cannula will look a little bit different than the wire in the sense that it is not a single bright structure, but you can see these sort of parallel lines indicating the outline of the cannula with the bevel tip here. This cannula is being inserted into the right atrium and hasn't made its way all the way down to the IVC where it must ultimately lie. Looking in the liver, again, here we see a close-up view of the hepatic portion of the IVC here running across the screen. In between clips, you can see a very brief view of one of the hepatic vein branches. And we can see that this cannula, again, these two parallel lines outlining the cannula, coming down into the hepatic IVC and not terminating in one of those hepatic veins. Finally, the exciting moment of truth. We have our cannula position and we begin ECMO flows. And when we put color flow Doppler, which is a tool in echo used to assess the velocity of blood flow, we see this very linear, bright jet of yellow and bluish flow that corresponds with high velocity. and the outflow flow from the outflow cannula of the catheter. And this is an ideal position because we can see it originates high in the right atrium, kind of toward the SVC, and is directed right above and through the tricuspid valve.
Dr. Cha and I wanted to share with you our pearls and pitfalls that we've learned throughout the development of this bedside cannulation program. And I first want to just describe what our program was like beforehand, in that we would always cannulate our ECMO patients in the operating room under both TE and fluoroscopy guidance. However, COVID really forced us to rethink that paradigm because we wanted to minimize the transport of our COVID patients throughout the hospital and minimize exposure to as many staff members as possible. And so we really were kind of forced to think about how we could do this safely at the bedside. I'd like to highlight that I'm a general thoracic surgeon without interventional catheter skills. And I highlight that because I think that means that many other professionals would also be able to safely do this at the bedside when they know how to do this with safe techniques that we're going to demonstrate and have hopefully highlighted throughout this discussion today. The first pitfall to think about, and what is perhaps the most feared complication of dual lumen cannulation, is that of right ventricular perforation. It can happen usually with the catheter going through the RV, but it could also happen with the guide wire poking through the heart as well. However, what I've found to minimize this risk is to make sure that you always use a guide wire that has distance markers on it, so that you can be well aware of how much wire you've placed into the heart and then into the IVC. The way that this complication happens is that the guide wire goes into the right ventricle before looping and then going down into the IVC. There, the echocardiographer is looking for the wire to be in the IVC for confirmation. However, that person may not realize that it's actually looped within the RV because it's such a thin wire that would have to be recognized, and it's oftentimes very difficult to appreciate. If you're using a guide wire with the distance marker and you limit the insertion of the guide wire to 40 centimeters or less, usually and ideally it's closer to 30 centimeters, but you want to make sure that the guide wire still extends into the IVC below the hepatic vein. But if you keep it less than 40 centimeters, it's impossible for the wire to have gone into the RV, looped around, and then gone into the IVC as indicated in this diagram. We found that this keeps it safe, and we haven't had the complication of RV perforation in our technique, and especially when we're able to continue monitoring under guidance. Now we'll share with you some echo pearls and pitfalls by Dr. Cha.
So again, in monitoring wire placement during the steps outlined, we do want to make sure that that wire not only ends in the right position in the hepatic IVC, but that it doesn't undergo any deformation or bending as the dilators or cannula are being applied. Sometimes we do see in this example that with the shear stress of the dilators themselves, although we can't see the dilators, we can see an applied force in this characteristic bowing or bending of the guide wire within the right atrium. Now, this is probably okay, but it is certainly vulnerable to being bent or to becoming out of position. And so again, you can see why continuous guidance is so important. Here we have an echo clip that again shows a outflow jet originating in the right atrium coming towards the tricuspid valve, but with this patient's hyperdynamic circulation positioned such that we see a lot of this color flow, I hope you can appreciate, swirling back around the right atrium, representing tricuspid regurgitation. And so this is probably a catheter that we would want to reposition. And usually what we would do is withdraw this a couple centimeters so that it originates a little bit higher in the right atrium and hope to minimize some of this TR. This still really demonstrates an important concept following cannulation. And what it illustrates is how dependent patient oxygenation can be on cardiac output or heart rate. And the reason for this is, again, we often see our patients have a very high cardiac output state. We often run our ECMO flows anywhere between 6 to 7 liters per minute, but depending on the patient's cardiac output, they may still have a significant shunt fraction. And with that shunt fraction comes some refractory hypoxemia. So rather than needing placement of additional cannula for drainage, we have employed a technique where we aggressively control heart rate with either beta blockers or other channel blockers, and thereby suppressing the native cardiac output and therefore shunt fraction. And what you see here are signals of both the patient's oxygenation represented by the pulse oximeter reading in blue, plotted against the patient's heart rate from the EKG signal in green. And again, these are near mirror images of each other such that we can see as the heart rate decreases, our oxygenation improves. And for many patients, we've even been able to identify a sweet spot or individualized goal heart rate range, which optimizes their oxygenation, as you can see here. This is another echo clip, which demonstrates a poorly positioned cannula. Here we do not see any jet or outflow from the cannula itself. Now we should see something organized and linear as in the past clips coming towards the tricuspid valve down here. But here we just see a lot of swirling turbulent flow in the right atrium. Now the cannula may need to be rotated so it's not positioned so posteriorly or withdrawn or advanced until we can see an outflow jet that is more appropriate. I put this echo clip to demonstrate that there are other ways to assess the cannula, especially after cannulation. Now, oftentimes we can see these cannulas may move over time, especially in these patients who have these cannulas in place for months. And using a surface echo or TTE probe can also be valuable and spare the patient an additional invasive procedure or insertion of a transesophageal probe. And so what I've done here is place in a transthoracic probe in the patient's subxiphoid area, and we are looking through the liver. This is all this tissue here, and specifically at the hepatic IVC running as a column across the screen here. And this yellow or blue flow, which is high velocity flow that represents the drainage through the cannula, is visualized within the hepatic IVC. And so there have been times when we can visualize both the cannula and the hepatic IVC drainage of the cannula under echo to continuously and in real time withdraw or advance cannulas that need to be repositioned. So a really important tool.
Finally, we'd like to share a case that we experienced pretty early on in our position that taught us a lot about what we were doing in the appropriate cannula position. This was a patient that we were consulted on for COVID-19 ARDS to consider ECMO deployment. And after our multidisciplinary team reviewed the history, we decided that this was a suitable candidate and we should initiate ECMO. If you notice and recall that I mentioned most of our patients have a right IJ central venous catheter already in place. This patient does not have any central venous catheters. And so the ICU team thought that we should, or that there should be a catheter in place so that we could support the patient throughout ECMO deployment. They actually even offered to place the right IJ catheter for us because we thought that that would be more efficient and save time for ECMO deployment. And we all agreed that was a great idea and appreciated the collaborative effort of the ICU team. So they placed their line and the patient still remained stable. We planned on performing ECMO and we did at the bedside without difficulty. It was a fast deployment and the circuit worked very well. The patient immediately, the hypoxia normalized and we had great flow on our circuit. And so we're all high-fiving that it was such a great deployment. This was during the middle of the night. Everyone went home. And before I could even get home, I get a phone call that the chest X-ray had been done, and after ECMO deployment. And what we see is that the patient actually had a significant right pneumothorax. And it's at the time it wasn't an issue, but as on our service, when we see that someone has a pneumothorax, we want to intervene to help re-expand that lung and to hopefully help the patient's recovery to be able to better utilize that recovering lung. So a decision was made to place a bedside percutaneous chest tube in order to help re-inflate the lung and resolve the pneumothorax. Fortunately, we used a crescent cannula in this patient because the crescent cannula has the advantage that the radiopaque markers show you exactly where the infusion or aspiration zones are. And here we've highlighted where the atrial infusion zone radiopaque markers are highlighted on this cannula. Now, mind you, this patient's still doing well, even with this pneumothorax, but now we're going to show you what happens when we place the bedside pigtail catheter. So now this is the post-chest tube chest X-ray, and fortunately we see that the lung is fully expanded. But now look again where the atrial infusion zone is, and we'll highlight it once again. Now, although the catheter is in exactly the same position where we placed it, the well-secured catheter, what really ended up happening after we resolved the pneumothorax is that now the mediastinum shifts back to its normal position. You see the right diaphragm is actually higher than before, and so now the atrial infusion zone is now below the diaphragm. And so that's why when we get a phone call after putting the chest X-ray or after putting the chest tube in, that now the patient's hypoxic, we have an explanation for it. And that's why it was great that we had these radiopaque markers. And so now we actually knew that we needed to retract and reposition the crescent catheter so that recirculation would stop or would be minimized, but to also have the atrial infusion zone back in the appropriate position. So once again, thank you for the opportunity to share our experience with our bedside dual lumen cannulation technique and program experience. I'd like to highlight and acknowledge many people and that are members of our multidisciplinary team that have helped take care and provide extraordinary care of these very sick and complex patients. Highlighting Dr. Bo Kim, who's our medical director of our ECMO program, as well as the other surgical and intensivists that are part of taking care of these patients. And also highlighting our advanced practice providers that have provided extraordinary care, along with our nursing staff, perfusionists, and respiratory therapists. Special acknowledgement goes to one of our nurses, Sophia Pon, who is one of the nurses in our ICU, but who is also a great photographer and provided all the pictures during ECMO deployment that you saw demonstrated today. Thank you.